Well, thank you everyone for coming. It's my pleasure to have you here this afternoon to hear about the results of a major research project that we've conducted here at Northwood in partnership with the Nova Scotia Centre on Aging. And I'm proud to introduce Dr. Janice Keith, who is the Professor of Family Studies and Gerontology. She's also the Lena Isabel Georgi Chair in Gerontology and the Director of the Nova Scotia Centre on Aging at Mount St. Vincent. And she is our principal investigator for the study. And I just want you to know that this study was funded from a national perspective from the Canadian Institute of Health Research. Janice is going to go over our results today, and then at the end we'll have ample time for questions and discussion. So I'll turn it over to you, Janice.
Thanks, Anne, and thank you for inviting me. It's a pleasure to be here. I've been told I'm not allowed to wander, which is really hard for me because I really like to wander around, so I'll try not to wander too far. I did want to mention that Anne McGuinness actually is one of the principal investigators on this research project. So she takes some joint ownership. There's only 3 of us. I'm the what they call nominated principal investigator. That means the money comes to my shop. And Anne is our key principal knowledge user, and we have Kevin Calloway, who's also an academic who is a principal investigator from St. Mary's University. So this is a little outline. Why did we do this research? This is what I'm going to talk to you about, what the rationale is, and just show you about the research team that's involved in the study, how we did it, a little bit about who we talked to, how many people, the kinds of questions we asked, and some of the key concepts that we were trying to understand and measure. And I'll look at the results. What did we learn, and what does the research say in this study? So the reason why we did this was that there were a lot of changes in our long-term care system in Nova Scotia, and partly, of course, because there was a wait list to get into long-term care, and there was an emphasis on building new beds and replacement beds. And so there was also, as part of that, and this building is an excellent example, these changes in physical layout of the new facilities. And there were changes in the way the staffing models, in who was giving care for what. And so we really wanted to understand what impact those changes have made in the lives of the residents who live here. So there's changes in philosophy around resident-centered care. And so we looked at those kinds of things, and we measured whether it improved residents' quality of life. And so that's what our basic study is about. And how did we get there? We worked with decision makers. We worked with people who work in the long-term care facilities. We work with other academics. We work with the government, Alzheimer's Society, Health Association Nova Scotia, to come up with what the question should be. And so this is our project team. There's quite a few of us here. There's 8 academics. There are about 15 knowledge users, collaborators from the actual sector. So it was a big undertaking with a lot of people involved. So this was our research question, and so we're asking, to what extent and in what ways do differences in nursing home model of care impact on resident quality of life? And so you see in the center here is the resident quality of life. We're looking at the physical environment, the layout of the nursing homes and how they're different, and the staffing models, and I'll talk a little bit more about those in a minute. And we recognize that there are different philosophies of care. And when we looked at this, we looked at resident quality of life, and it had 4 different components. We used a measurement tool called InterRAI, resident quality of life, and when we used that tool, we found there were 4 key areas that really affect quality of life of residents in nursing homes. Food, very important, is food. Care and support, what is the kind of care and support that's being provided? autonomy. How much freedom, autonomy do residents have? And activities. What is actually going on in the home? And we had models of care. So these are our two concepts, quality of life, models of care. So we divided our 23 different study sites, of which Ivany Place was one, into these three different organizing concepts. So we had, and we did that by whether or not they were new, the physical design was different, and their staffing models. So we end up with new full scope, which is small, it's new, they have the small self-contained households, like here at Ivany Place. And the CCAs, the continuing care assistants, are responsible for all tasks, including dietary and housekeeping. In the new augmented, they are again the same physical design with households, like Ivany Place, and the CCAs provide care with some limited dietary and housekeeping. And so that is actually what Ivany Place, that's the category that you would be in. And then we have the traditional facilities. So the traditional facilities, there are floors and units, as has been in the past. And the CCAs only provide the personal care. There's other staff that provide housekeeping, and there's other staff that provide dietary services. So an example of traditional care in the Northwood community would be Northwood downtown. But there were many others in that traditional area. So keep in mind, we had 23 different study sites. We had 23 different study sites, and we talked to and surveyed a lot of different people. So we talked to residents themselves. We did interviews with about over 300 residents, and we followed that up with some in-depth interviews with the resident. We had over almost 400 surveys from family members, contacts with family members. We did that first of all with a survey, and then we followed up some of our findings by having small groups get together. We call them focus groups, around some of the deeper understanding of what they told us in the surveys. We had staff surveys, many of which were done online. Over 800 staff participated in the survey. We extended it not just to the study sites, like the 23 nursing homes. We actually invited other nursing homes in the province to participate. And so there were another 40-some nursing homes from elsewhere that participated in the staff survey. And the good news is we actually, because we're very frugal, we have a stingy management team. We actually have money left over, and we're going to be able to do a second wave of the staffing survey. So that's important because that's going to start in a few weeks. We also did surveys with seniors administrators about some of the characteristics of the home, and we had a profile of the nursing home itself. So things like the physical building, how old it was, and so on, some characteristics of the actual place. Then we followed what we call care constellations. So there were 6 cases that we identified and requested participation in, and 3 of those were with people who weren't able to speak for themselves. So this is one of the challenges of doing this research, is that the residents that we spoke to, of course, had the capacity to be able to have the conversation with us. And we know that not all residents have that capacity in our nursing homes. So we wanted to figure out a way to understand what was happening with their quality of life. So we chose this approach called case study. So we followed residents by talking to their family, by talking to the staff that serve them, and by talking in some cases to the residents themselves if they were able, as well as actually being in the space. We did what we call participant observation. So our graduate students would actually sit in the area and observe interactions with that particular resident. So we did that over a year period of time at 3 points in time, because we also wanted to understand how things might change or evolve as time went on. So there's a lot of data. And so if you know anyone who's looking for a thesis project or a research project, we got the data. I should mention with the case study too, we also measured how much activity the resident had. We had these little gizmos they put on their arm so that we could tell how active they were as well. So this is just a summary of the actual numbers in the study. So as I said, there is almost 400 family members, and you add the two staff from I said 40, but it was 36 additional sites. So there's about 862 staff who participated in round one. And we have profiles of the nursing homes who participated, our 23 study sites, as well as 34 of the 36 gave us profiles as well. So, some findings. So I want to talk to you a little bit about our first finding, which is the quality of life of the resident. And so if you look at the blue, that's the resident, and it's by the three different types of models of care, we call them. And so you see they're fairly consistent, although slightly lower in the traditional facility. But let me just say first, I should have said this at the very beginning, contrary to some of the negative press that have been in the print media lately, there is a relatively high perception of quality of life in long-term care facilities, whether you talk to the residents, the staff, or the family. So where the Chronicle Herald reporters found those families who were disgruntled, they didn't talk to the families that were participating in our survey. I would say, though, there is some significant differences here, and I want to point those out because it's not all positive, and I think that when you hear the way the results unfold, you'll see ways that we may be able to improve the resident quality of life in our homes. So if you look at the blue bar, and that's the perspective of the family. So you see that actually the family whose resident is in a long-term care facility in a traditional type of an environment with floors and units, those family members felt that their residents' quality of life was significantly lower than the residents in the other two new design facilities. So there was some suggestion that the family felt that the resident or perceived their quality of life less to be lower in those facilities. And as well, the staff was slightly lower, but still significant in the traditional facility vis-a-vis the other two facilities. Okay, so now I'm going to go through each of the perspectives. So I'm going to do the resident perspective first, then the family, and then the staff. Thank you. You should be doing this, Anne. So just to tell you about these three groups. 319 residents talked to us. We filled out their survey with them. Most of them were women, 73%. Most of them were, well, over the age of 65, obviously, over 80%. But almost 40% were over the age of 85. So that's pretty significant. 18% were married or common law. And again, some university, 26%. Interestingly, almost half had lived in the facility for over 2 years. And of course, because they were able to participate in our study, 80% of them had mild or no cognitive impairment. And so that's an important feature of this because it's not really representative of the actual population of a nursing home. It's representative of the population of the nursing home who is able to participate in the survey. So as we heard from the administrators in the profile, their homes have from between 40% to 96% of their residents would be moderate or severely cognitively impaired. Okay, so just keep that in mind. We are talking to a particular group of residents. The family members, about 400 of those individuals, again, 80% or almost 80% are female. 55% are retired. This is the one that I love to tell my students because they actually think you're old when you're 65. They have no idea. In fact, pardon me? I said, are you kidding? Are you kidding? Exactly. They've only started. You're 85, see? Yes. 65, they're a baby yet. Yes. They got a lot to learn from the 85-year-olds. Actually, many of the people who were participating were family members. About 2/3 of them were the children of the resident, and many of them were over the age of 65. So, you know, I say once you have 65, you're likely then possibly caring for an elderly parent. Many have been, 26% were primary caregivers when the individual was in the community. They were very involved in the care. 61% had visited at least once a week to the nursing home, and those visits lasted a significant length of time. And as well, many talked to the resident on the phone. And the people that they're talking about, again, very elderly. They're over half are aged 85 or more, and 42% have been in that nursing home for 2 years or more. Okay. So the staff, 862 I indicated. Again, if you look around, most of the staff are women, just over 90%. The average age was 43. In the, we included all different types of staff, and so in the makeup of the staff, about 60% were the direct care staff, either CCAs, registered nurses, or LPNs, yes. And 2/3 of those were full-time staff. And their length of tenure, how long they had been at the current nursing home, was just over 8 years on average. So we looked at those 3 different groups, and we tried to figure out what, in fact, contributed to resident quality of life. So if you remember, there were different components for different resident of quality of life seemed to come out differently, whether it was in traditional facility versus the new facilities. When we do this research, what we can do is we can control for these other variables and see which of the other variables actually make the biggest difference in quality of life. And that's what this is showing you. So for the resident, is it going to, oh, no, it's not. Okay. So for the resident, things like marital status, health status. So if you were healthier, you had higher quality of life when it was controlled for everything else. I have to tell you, there is a weird finding here, and that is marital status. So the people who were married had lower quality of life. Don't know. Some people aren't surprised at that. We were thinking that it's possibly because people are married but not necessarily living together in the nursing home, that one person. Okay, we're not going to go to your situation. No. One thing that came up, and it's important from all perspectives, was home likeness. How homey was the facility for the residents? The personal relationships that the resident had was very important to them and was influencing resident quality of life, and the resident to staff bonding. So the last 2 items are about relationship the resident to staff bonding, how much they were able to reciprocate, the kinds of things that were important to, from the resident's perspective, to be friends with the staff member. Family, the resident cognitive status, the more the person had a cognitive impairment, so the more dementia evidence, the less perceived quality of life of the resident. Homelikeness again became important, as well as the relationships. Family to staff, was there mutual respect, these kinds of things in their relationships, and resident to resident relationships. Was there opportunities for their family member, the resident, to have relationships with other residents in the facilities? When it came to staff, there was a different type of questions, because in this area, we actually asked a lot about the working conditions of the staff in the home, and whether the way the conditions would have impacted on the perceived quality of life of the resident. And so we did find some differences there. We found that new homes with full scope, they were most likely to contribute to perceived resident quality of life. Homelikeness again, relationships come in as important, the resident to the staff relationships. Now this is from the perspective of the staff. But then there's a series of workplace characteristics, like role clarity. They knew what they were supposed to do. Like skill use, they were able to use the skills that they had in their toolkit to be able to provide the care. And transformational leadership, that they had a vision, that there were people, their supervisors enabled them to provide positive influence into the care that was being provided. And finally, residents with challenging behaviors was negatively affected the perceived resident quality of life. So the more challenging behaviors, then the lower perceived quality of life of the resident from the staff. So essentially, to answer the research question, which was this, what impact does these new models of care, whether it's physical design or whether it's staffing models, what impact does that have on the actual resident quality of life? We didn't really find a direct relationship between these two items, but rather that it was through this concept of relationships and home-likeness. So the models of care help to facilitate those type of characteristics, those concepts, and that if it was good relationships, positive relationships between staff and resident staff and family, etc., then that's what was mostly contributing to resident quality of life. The first result is relationships matter. Surprise, surprise. No matter who we talk to, whether it was the resident, the staff, or the family, we found that they were the key elements in supporting a resident's quality of life. And that included residents' personal relationships, that they were able to have friendship and companionship. Playing a significant role in other people's lives was important to them, and there was space, that the home had opportunities for them to develop those type of relationships. When we looked at the case study, the other thing that we found was reciprocity was a very important factor, and reciprocity means being able to give back. So you're not just receiving care from staff, but you're maybe commenting them on, how nice they look today, or you're helping them in little ways. You're helping them to do their work, and as a resident, they're providing support for the staff. So it works both ways, and that was really important in the case study. Also important was the sense of familiarity and continuity of the staff, so that you can't really have relationships unless you get to know each other, right? And so having that continuity of staff was felt to be very important from the case study perspective. From the family perspective, it was in fact being part of the team, that they felt like their voice or their value was important. So for resident to staff, we found mutual respect and friendship, openness and communication. From the family and staff, again, that there was friendliness, there was respect, and they were able to share their concerns, communicate, and what they heard back from the staff was things that they could understand. The second key result was home-likeness. What do we mean by, so we're going to talk about home-likeness. It feels like home. There's a sense of an attachment to the facility that people live in. There's a warmth that's there. In some ways, it looks like home. There's some amenities of that facility. There's some characteristics of the building that feel like home. There's importance of it being clean. And the other thing is that there are people from the community coming in, so it's not all the same individuals. And so this was, whether it was the staff, the family, or the residents, this was another key element. When we went to the nursing home, or the case studies, an interesting relationship or connection occurred in that relationships became sort of the pathway through which we understand home-likeness. So having that relationship made the place more like home. And from their perspective, having control over space, their personal space, what they did, was also important around understanding home-likeness, because they did what they wanted to do when they were at home, and if they could do that at the nursing home as well, it was very important to them. And finally, this is only for the staff, of course, but another key result is the working environment, that these elements of the working environment were really helped to support positive perceptions of the resident quality of life. So again, role clarity, knowing what to expect, learning new things, being able to use the skills that they had acquired, and this concept, this idea of transformational leadership. And these are some of the characteristics of that. That the staff receive encouragement, that they receive recognition for the good work that they're doing, that they're treated as an individual. We're talking about the staff now. They are allowed and encouraged to problem solve. They're trusted, and there's a real sense of cooperation among the staff. And similarly, enabling that to occur within the case study, that sort of working condition, was that familiarity piece as well, that they are, as staff, that they're familiar with the residents and that they have a consistent staff assignment, and that helps their working condition, helps to have a good, positive working condition. So that's the main results. Before we go into discussion, I look forward to hearing what you have to say. I just really want to thank the staff, the family, and the residents especially for the time that they took to participate in the study, because without the voices of those individuals, we really wouldn't have a good, solid evidence about some of the ways in which these new nursing homes, or some of the factors that seem to be very important in the perceived quality of life of the residents. So thank you very much to everyone who participated, and especially thank you too to the administrators and the staff that helped us as a research team get access to the homes and to the individuals, and encourage people to participate. We really do appreciate the time and the effort because research is not always high in the priority, and we're happy to be able to participate with the homes and also to be able to share back with family and residents and staff some of the results that we heard. These are many of our funders, the Canadian Institute of Health Research and the Nova Scotia Health Research Foundation, as well as the Alzheimer's Society, who's funding these events, and then a host of universities and nursing homes who are participating. So thank you.